Okay, it's now time to start. Good morning, good afternoon, good evening, wherever you are. I hope you can hear me loud and clear. My name is Jane Chuma. I work for the World Bank. I'm based in Nairobi. I'll be your chair for this session. So welcome to this session on strategic purchasing reform. We have three presenters. Unfortunately, one of our presenters has not been able to join, which is not so bad because then I think we have a bit more time for our presenters, but also a bit more time for discussions. So because we are less one presenter, I will give each presentation 10 minutes. I kindly request the audience that we hold on to our questions until the end of the presentation. So kindly, we are going to take the three presentations, and then after that, we are going to open up for questions and discussions. We also can take advantage of the chat box. So if you have any comments, you can put there, but I would like to encourage that we kind of interact during the questions session and not just do some chat. So thank you very much. Our first presenter is Yan, and Yan is going to tell us about medicine pricing reforms in China. She is a postgraduate from Peking University Health Science Center. So Kaite, please put up your presentation. After that will be followed by Funke and then by Miranti. So over to you, Yan.
Excuse me, I'm sorry, I'm not sure whether you included me. So I'm the second speaker.
Oh, I'm sorry, we have been looking for you. I think you are showing up differently.
Yeah, so I'm sorry for that. So
yes, okay, you come second, and my apologies. We've actually been looking for you.
Sorry for that. I could not join a few minutes before, so.
Yeah. Okay, you come second and then Funke. Thank you very much.
Thanks a lot. So you have to, go back to the original times, right?
So we stick to our 8 minutes, presenters. Thank you.
Okay. Hello everyone. My name is Sun Yan from Peking University Health Science Center, and today my study focuses on the impacts of national drug price negotiation on expenditure volume and availability of targeted anti-cancer drugs in China. It is a controlled interrupted time series analysis, and I'm Sun Yan from Peking University Health Science Center. Targeted anti-cancer drugs is believed to have fewer normal tissue toxicity, higher efficacy, higher price, and higher expenditure. The soaring health expenditure has been a problem faced by many countries in the world, and a strategic procurement is also adopted by many countries to control the overall health expenditure. In China, the availability of and affordability of targeted anti-cancer drugs was quite limited before 2017. We could see from the chart on the right side that in 2016 there were only 2 innovative molecules approved in China, and this figure is 42 in Japan and 34 in Australia and 62 in China, Taiwan, it also took a longer time for a new molecule to be included into reimbursement list, and we could see since China. We could see in 2017 this figure is 54 months on average in China, compared to 14 months in China, Taiwan, and 16 months in Australia and 2 months in Japan. Facing these challenges, China has initiated 5 rounds of national drug price negotiation targeted to include more innovative drugs into reimbursement list from 2016 to 2020, with an average price cutoff from 44% to 60%. For example, in 2016, it included 3 chemical drugs into reimbursement list through negotiation, and in 2017, this figure increased to 31. At the bottom of the slides, we could see it is a timeline for the adjustments of NRDL in China, and we could see that before 2016, it has been 7 years that China did not making any adjustment to its NRDL. So the national drug price negotiation is quite important. This survey focused on the second round of national drug price negotiation because in the 2016 negotiation, it included only 3 drugs, and the second round negotiation established a framework for later negotiation, which we could see from below side. It has preparation, evaluation, and negotiation and procurement, the full procedure. And in 2017, 23 provinces implemented the policy in September, and it's in the red color, and 3 provinces in October, and 2 in November, and 3 in December. We applied procurement data to analyze the effect of this policy. It's from the January 2017 to September 2018. It was collected from CDSIB. It is a national health commission platform collecting the procurement data from every provinces. It contains the procurement information from every public hospital in China. We extracted procurement data of 31 chemical drugs in 31 provinces. However, we choose only 3 drugs in 11 provinces due to the following reason. The first is the quality of regulation data is relatively low, and the missing data is not missing at random. So we just excluded the molecules that have the missing data more than 2 months. So in the end, we choose 3 drugs in 11 provinces, implemented the policy in September as the intervention group, and they are rituximab, trastuzumab, and recombinant indocin. And we choose another targeted anti-cancer drugs as the comparison group, is the Pegas. We conducted a controlled interrupted time series analysis. And we choose 3 independent variables. They are monthly average expenditure, monthly average volume, and availability, measured by number of hospitals in which the medicine was procured, divided by number of hospitals uploaded procurement data. And here's are my main results. We could see that after the implementation of the policy, the total expenditure the growth rates of total expenditure increased for intervention group compared to the control group, and sorry. For the overall volume and expenditure, we noticed an increase in growth rate, and no immediate change was observed. And for availability in all hospitals and availability above county level, we noticed an immediate increase in availability, and an increase in growth rate of availability. and the effect seems to be different across different regions. For example, in Eastern China, we could see that the coefficient is 0.04, and for Middle China it is 0.21, and we could see that the effect seems to be higher in the Middle China compared to the Eastern China, which is more richer, more wealthier, and to the Western China, which is uh, uh, where the GDP capita is relatively lower. This is also the case for overall volume, and we could see the coefficients in Middle China is also the highest, and the coefficients in Eastern and Western, they are relatively lower. It is also the case for the overall availability. In the end, we could conclude that the national drug price negotiation in China increased the volume, expenditure, and availability of anti-cancer drugs and achieved the expectation of the policy for guaranteeing patients access to these drugs. And the effect of the policy seems to be different across Eastern, Central, and Western China. And in general, Eastern region have the highest GDP per capita in China, and the Western region have the lowest. And it implies for the result might be the effect of threshold effect. This study also have some limitations. For example, we included only 3 anti-cancer drugs out of 16 negotiated anti-cancer drugs due to the data limitation. And the data was calculated and extracted in provincial level. No patient level data was adopted, which could provide more helpful insights into for us. And the comparison group only has 1 molecule due to the data limitation, and more molecules should be included if the data permitted. Thank you.
Okay, thanks, Yan. We are going to proceed to the next presentation, which also continues the conversation about pricing of medicines. So can you put your presentation up? Thank you. The second presenter, I'm sorry, I'm not able to, I don't want to attempt pronouncing your name. Kindly,
yeah, sure.
introduce yourself and put your presentation up.
Great.
Thank you.
So, yeah, welcome everyone. My name is Afshin Ganjur, and I'm happy to provide the presentation. So, it's about pricing orphan drugs. And so one of the fundamental questions is price of orphan drugs. So if we, I mean, generally in Western countries, at least, there's a trend towards value-based pricing. So the price of a drug is determined of new innovative drugs. The price is determined by the level of health benefits, as well as other value components such as cost offsets. The question is whether orphan drugs should receive a higher price due to the small patient population, because if we assume that R&D costs are largely fixed, then due to the smaller patient population in orphan drug designations, the R&D cost per patient is higher, and therefore the question is whether orphan drugs should receive a higher price. And what I will present is a compromise between value-based pricing of orphan drugs and cost-plus pricing. I mean, cost-plus pricing would be based only on R&D costs, value-based pricing only on value, and I present a model that strikes a compromise. So the underlying model is a Bayesian model. So basically the idea is to update prior knowledge with new data. This is shown in the middle. So basically we have prior knowledge. So this is, and there's a weighted averages calculated from prior knowledge and new data. And the weight is represented by the proportion of the total variance explained either by the new data or the prior knowledge. And if we translate this model to our problem in question, the weighted average we calculate is a weighted average price. And the prior knowledge is the price based on cost plus pricing, CPP. And the new data that is collected are the data on the health benefits. So it's a price based on value-based, based on the value. And the weights that I use are, again, it's based like in the normal Bayesian model. It's based on the variances of health benefits and R&D costs. So we would weigh the cost plus price by the proportion of the total variance explained by the variance of in health benefits. So that's the fundamental idea. So yeah, that's the equation. And now the question is, now let's assume we don't have any information or just information from one patient regarding value. So essentially no information. So the decision maker is agnostic. Then the R&D cost weight would decrease by 2 times the total population, right? So if the total population increases, the R&D costs would decrease, of course, and it would decrease 2 times as fast. And now if we if information on health benefits is collected in a trial, then the variance needs to be adjusted accordingly, and it would be 1 divided by n, the number of patients that are included in the trial based on the standard error of the mean calculation. And then if we do the calculation, the R&D cost weight would decrease by n total, that's the total number of patients, plus, that's the last, that's shown in the last row, plus product of the number of patients in the trial times the number of the total population. Yeah, so if we, for example, do an application example here, we have total population of 10,000 people, R&D cost is 1 billion, value-based price is 50,000, and the health benefit is 1 unit per year. Then if we don't have information just from one person regarding health benefits, then the R&D costs would decrease by 2n. 2n is 2n, and the price would be 75,000, right? With the value-based price, the value-based price is 50,000, right? And then the price would be increased due to the consideration of cost plus pricing. So there would be 25,000 in addition. And if we also consider, let's say, a trial that has been conducted around 100 patients, that means we have more certainty now, or decrease the uncertainty around health benefits, then the price would decrease to 50,990. Now, this would provide, strictly speaking, a disincentive for the manufacturer to collect data on health benefits, right? Because it would decrease the price. But on the other hand, the manufacturer is forced to demonstrate or show information on health benefits to pass regulatory and reimbursement hurdles. So therefore, he cannot simply minimize the number of patients enrolled in the trial. Okay, so if we show the results here in this graph, we have on the x-axis number, the target population number, on the y-axis the annual treatment cost, and so for patient populations, let's say less than 20,000, cost plus pricing would yield the highest price. So with additional evidence available on health benefits, the price would be lower. Yeah, so that's the result essentially. So you can compare the price based on the different types of different models. So The question is whether if we use value-based pricing for pricing orphan drugs, whether there should also be consideration of social preferences, altruistic preferences for patients with orphan drugs. I mean, some studies have, elicited societal preferences and have shown that, there is a concern for rarity in the population, and this would increase the value-based price. And I mean, the cost plus pricing is essentially a reflection of this altruistic concern, because the maximum altruistic price is simply the cost plus price. I mean, we would never charge more than the full R&D cost, reimburse the full R&D cost plus an additional margin. So this is already included in the model, this altruistic concern. Okay, so that's so the model I presented is a Bayesian model, and it strikes a compromise between cost plus pricing and value-based pricing, and the R&D cost weight decreases with N plus product of the number of patients and the number included in the trial. So that's it. So thank you very much.
Okay, thanks very much for that presentation. As we agreed earlier, let's save our questions, comments, and points out for discussion until we have completed the presentations. Our third presenter is Funke. Funke, kindly, you put up your presentation and introduce yourself. Thank you. So we change the conversation a little bit to talk about the benefit package, and we move to Nigeria. So Funke, over to you.
Yeah, thank you very much, Jane. Hello, everyone. As Jane had said, my name is Funke Falade. I'm from Nigeria, and I'm going to be talking about some of the strategic purchasing reforms that are happening in Nigeria. Myself and my colleague Carlos Avila undertook this research. So first, some background about Nigeria. So Nigeria is the most populous country in sub-Saharan Africa. We have a population of about 200 million people. It also has the largest economy in Africa. Nigeria is a federation, and what that means is that, there are 36 federating states and one federal capital territory. And some of the government functions are shared across the national government, or what we call the federal government, and the states. And one of those is health. So health is implemented by the federal government, also implemented by the state government and the Federal Capital Territory Administration. Now, Nigeria has been grappling with poor health indices for quite some time now. An example is the maternal mortality rate as at 2017, which was estimated at 556 deaths per 100,000 live births. And when you compare this to the average for the LMIC groups, which is at 265 maternal deaths, you can see that Nigeria is more than double those. So one of the things that Nigeria started to do was to look at what reforms, it could implement to stem the tide of these poor health indices. And one of the key problems for these health indices, or that led to these health indices, was the poor financial accessibility of services. And so Nigeria started implementing two key strategic purchasing reforms. The first one was the Basic Healthcare Provision Fund, which we call the BHCPF in short. The BHCPF is funded by 0.5% of the federal government's total revenues and is expected to provide a benefit package of services to Nigerians free of charge at the point of service, because it's paid for by the federal government. The second of those strategic purchasing reforms was to, alongside the BHCPF, get every state to set up a state health insurance scheme in order that they can qualify to receive the BHCPF and administer the BHCPF. And that these state health insurance schemes should also commit to setting up their own health benefit plans that will now be provided to people who are willing and able to pay for these health benefit plans. And given these strategic purchasing reforms, our research questions or the objectives of our research was to look at how well the benefit package of services defined by these schemes, the BHCPF at the federal level and the state health insurance schemes, aligned to the overall policy objective of improving maternal and child health indices, because that was one of the key flags, for setting up these reforms and flagging off these reforms. We also wanted to look at how well, these strategic purchasing reforms could feasibly make Nigeria start the journey or progress rapidly on the journey towards universal health coverage, given that Nigeria is one of the signatories to the UHC commitment. And in order to get information about this, we obtained 7 different benefit package of services. One was from the National BHCPF. We obtained from 6 states across 5 geopolitical zones, 5 of the 6 geopolitical zones in Nigeria. And we had 4 key questions. The questions were, what is the breadth or the class of population coverage for each of this benefit package of services or each of these schemes? And what was the depth and breadth of services covered within each of these schemes? And then what explicit service guarantees were provided within each of this benefit package of services? And what was the financial coverage and cost of this benefit package of services across the 7 that we examined? So our results showed, variability in terms of our research questions. And on one hand, this wasn't surprising because, as I have mentioned, I think repeatedly, we're just starting these strategic purchasing reforms. They are less than 5 years old. And so we expected that, it would take some time to see standardization and proficiency in how these schemes and the benefit package of services are being designed and defined. On the other hand, it was a bit surprising to see the breadth of, the variability across the different benefit package of services. So I'm going to dwell on this table for a couple of minutes or so to explain our results. So the first row of this table, we can see groups of services. So we have maternal health, child health, infectious diseases, and we also have NCDs. And in the row immediately below that, we have specific health services under each of these clusters that we had identified and we had covered in our research across the benefit package of services. And then in the first column, we have the different states that we looked at and the BHCPF that we looked at. Now, the first thing we saw, if we look at the second column of this table, is that even in terms of the total number of health interventions covered, there was great variability. So we have Bauchi State having 75 interventions, FCT having 74, and then we switch over to Lagos having 14 health interventions defined and Cross River having 36. So there's a wide range of variability there. In terms of the number of interventions covered within each service, we also saw a lot of variability. So an example is family planning. For BHCPF, there are 5. For BHCPF under family planning, there are 5 distinct interventions that we could identify. For Bauchi, there were 7 distinct interventions that we could identify. For the others, basically the others that had one only had family planning counseling. There didn't have provision of any commodities for any methods or any other methods, modern methods in there. And then there were some that were not specified, which I will get to in a minute. So we see that in terms of how many, like the the breadth of coverage of a specific service across states. Some services enjoyed better coverage. So for example, ANC was covered by all the states, assisted delivery was covered by all the states, postnatal care and cardiovascular disease was covered by all the states to some degree. But when we look at things like non-tropical, neglected tropical diseases, tuberculosis, cervical cancer screening, we can see that they enjoyed or they didn't enjoy as much patronage across the health insurance schemes as the other services. Now, you'll see that there are a lot of N-S within the table, and what this means is not specified. And for each of these services where we wrote, and states where we wrote non-specified.
Okay, I try to summarize. I've been sending some messages. The time is up, so maybe 30 seconds.
Okay. Okay, yeah. So for the non-specified, and that was the most interesting thing about our research, was that some of the states had defined services at a very summary level without identifying the specific interventions under each of those services. So for example, ANC, we weren't sure for Lagos, we weren't sure what exactly was included in ANC. It was just included, you know, as a composite service. And this was worrying because we knew that this could affect the level of quality of those services and the interpretation of what is available to populations for those services. And it also affected the pricing, because if you're not able to price disaggregated services, then obviously your prices are going to be skewed and are not going to be representative of, you know, what it is of the actual service that you are trying to offer. And we saw that variability in pricing between a difference of about 400% in pricing across the different benefit packages. So overall, going back to our questions, we saw that the analyzed benefit package of services did include a lot of about 65% of the MCH interventions. However, explicit guarantees and feasible financing strategies need to be explored to be able to ensure long-term sustainability and achievement of our objectives. Thank you.
Okay, thanks, Funke, for that interesting presentation. We now move to Indonesia. Miranti, kindly put your slides up and introduce yourself. Thank you.
Thank you, Jane. Let me share my screen first. Okay, good morning. Thank you everyone for giving us this chance. It's really an honor for us to be here. And allow me to introduce myself and my partners. My name is Miranti Ratnafuri and my partners are Chandra Ikhdan Rohman and Tedo Arya Trisnanto. We are from BPJS Kesehatan, the National Health Social Security Agency of Republic of Indonesia. In this opportunity, we would like to give you a short presentation about the detection and investigation of fraud in national health security on the primary e-claim basis. BPJS Kesehatan is a public legal entity mandated to manage the National Health Security Program with burdens and accountability principles. And as the only health social security provider in Indonesia, BPJS Kesehatan has cooperated with more than 22,000 primary care providers as of the first semester of 2020, and by the end of 2020, we have cooperated with more than 23,000 primary care providers. And around 82% of those primary care providers claim their non-capitation services they have been providing every month. And as we can see from the chart shown in this slide, that along with the increasing access to a health service, the utilization service also increasing from 2014 and 2019. With the increasing access, which also has a positive impact on the quality of life of our participant, of our health social security participant, or as we call it here is JKN, the possibility of fraud and abuse in health financing at the primary care also increases. So in 2019, we developed an electronic claim-based for primary health service integrated with a verification feature. It is as our effort to simplify the claim submission process as well as to detect potential fraud. The principle of this primary e-claim is to ease our providers in submitting claims, also minimizing claim files and increase the certainty in claim payment. So in addition, through this primary e-claim, adequate data entry can be obtained to ensure that the service is properly provided to participants. Okay, we are using empirical data. From the chart on this slide, on the left chart, here is showing the average claim settlement, the service level agreement before the e-claim era, and the right chart is showing the average claim settlement after the e-claim era. From this chart, we can see that there is a shift in the claim settlement of N-1 claim. So the use of primary e-claim can adequately improve the service level agreement quality of N-1 claim settlement by about 4.79%. Other than improving the quality of claim settlement, e-claim also has a positive impact on potential fraud detection. It is increasing the ability to detect inappropriate claims from 0.25% in average in the pre-e-claim era to 1.46% in average in the e-claim era. It means that it increased the ability to detect potential fraud by 1.21% of all non-capitation claims. And as of the first semester of 2020, the data shows that the primary e-claim is able to detect potential fraud claims worth around 11.6 billion rupiah, which is a very significant value when we compare to the total financing of the non-capitation basis. So, in conclusion, the primary e-claim can improve the primary care provider compliance in submitting their non-capitation claim. Also, the implementation of this primary e-claim has a positive impact on the settlement time of non-capitation claim by 4.79%, which we hope it can increase our provider satisfaction. And also, the primary e-claim also increases the ability to detect the potential fraud by 1.21%, which has an impact on efficiency around 11.6 billion rupiah. That's all from us. Thank you for your attention.
Okay, thank you very much. I think we are doing well in terms of time, so I will open the floor for discussions. Kindly raise your hand if you have any questions or comments, or also feel free to put them on the chat. Anybody who wants to go first? Okay, maybe as we are reflecting, I can kick off, and perhaps we can have a discussion about the use of procurement data in some of these analyses. Maybe Jan, you can tell us a little bit more about the quality issues you had and the challenges with the methodology, and request that the team can give feedback. I would also request that we have a conversation about the benefit package and the implications on the design and explicitiveness in equity. But before we start, maybe anybody with a question or comment? I can't see any hands up. I know it's a bit early in some places, a bit late in others. Anyway, so Jan, maybe you can kick us off. Okay, yes. Is it Deb? Please, Deb, then Abby. Thank you.
Thanks very much, Jane. I just actually had a question for the first presenter from China, and that was very interesting. Thank all presentations. Thank you very much. I was just wondering, you mentioned the constraint of out-of-pocket expenditure, or I think you mentioned in Western China the constraint of patient spending in this case might be why you didn't see the increases in the medical expenditure for those drugs in that region. And I just wanted to check, is that because a large proportion of the drug expenditure would fall to the patient rather than in the hospital claim in that area, so the provider costs? And does that differ between the UEBMI, the employee insurance, versus the NCMS, the rural insurance that more people would actually perhaps have in that region?
Okay, thanks. Let's take one more, Abby, please. Then we'll discuss.
Okay, thank you. I am Abay from Ethiopia. My question will go to Miranti. I think she was presenting on the e-claim analysis to detect fraud. By the way, what kind of provider payment mechanism are you following? Because if it is like, for example, capitation or fee for service, it will matter how much the volume of fraud will be. So can you explain us and how much these detection techniques can alleviate your problems? Thank you.
Okay, thanks. I suggest we take that and then we have another round. Please also feel free to post comments on the chat. Thanks. We can take any order. Jan, maybe you can go first, and then Miranti can come in.
Okay. Thank you for your question, and it is a very good one. Let me introduce further to the insurance system in China. That the China have a basic insurance platform that have three basic insurance. They are UEBMI for the employed, for the urban employees, and URBMI for the unemployed urban people, and NCMS for people in rural area. But the NRDL is for national drug is a national reimbursement drug list for basic insurance, and if the innovative drugs was negotiated successfully, and it could be into the category B of the national reimbursement drug list. Drugs cut off by about 50% after they are included into reimbursement list through negotiation. It would it would release the heavy burden, the heavy economic burden of 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 people. But since the people in the Western area, their income and their GDP per capita may be relatively lower, so it may still difficult for them to pay even after the price the drug price is cut off and it is got reimbursement. Thank you.
Thanks, Sun Yan. 谢谢.
Yes, Milante, please proceed to respond to the question. Thanks.
Okay, thanks, Jane. Thank you, Abai, for the question. Here in BPJS Kesehatan, we have two types of payment system in the primary service. The first type is capitation, and the second one is the non-capitation. The capitation payment is we pay in some kind of a lump sum money to our primary care providers. And then we also pay with a non-capitation payment. So the primary care providers can claim some of their service that they give to our participant, and then they claim. It's more like it's like a fee for service payment, but we have fixed rate for the non-capitation payment. In detection, we have rules and we have logic that we implemented in our application, that we got the rules from our experience in managing those claims. That's all for me. Thank you.
Okay, thanks. We have a few more minutes, so I will still give participants a chance to raise any questions and comments, particularly on the presentations that we haven't had any reactions to. Okay, Stephanie, Debbie, is that a new hand or it's an old one?
It's a new one. Or sorry,
okay.
It's an old one for me, Jane. Sorry, I'll put it down.
Okay, Stephanie, do you want to go ahead?
Sure. I have a question for Olufunke on the Nigeria presentation, which was very interesting. I was wondering if you think there will ever be movement towards unifying the benefit packages across Nigeria to avoid disparities across states, or if you think, given Nigeria's unique political situation, if you think it will always be managed more at the state level and without a unified package across the country. Thank you.
Any other comments so that we can respond together? Okay, Funke, please take that up.
Okay, thank you very much, Stephanie. That's a great question. So technically, we know, I think everybody like in the health financing space or health system strengthening space knows that we need to move towards unification in order to be able to get rid of some of these variations that we see. But just like you mentioned, Stephanie, there are a lot of political considerations that will prevent that from happening. As you rightly said, Nigeria, I mean, the way Nigeria is structured with each state being independent and autonomous, it needs somebody or an agency or something with some political power and authority to be able to convene everybody together, all the states, and have them all agree to move towards uniformity. Another way that I see it happening, and these are discussions we're starting to have, right? Because you know, there's been a lot of research about how contributory health insurance, especially in countries with a large informal economy, contributory health insurance can't really lead us to the promised land. So conversations we've been having are the possibility of some kind of general tax financed health insurance or health coverage for all the populations. And that's really hinged on making BHCPF the key pool and having all states and everybody else who wants to contribute into that pool, so it becomes a national thing and it becomes uniform. So those are those conversations are still they're still in very early stages, and I would say that before we see some unification, it will take some time, unless something radically changes in terms of the way Nigeria is organized or our politics. Thank you.
Okay, thanks, Funke. I think I have actually a comment. It's not a question, but it was not surprising, but interesting to note that the core services that relate to maternal and reproductive health, which are supposedly free, are not included in the package, and then perhaps people end up paying for it. This is a very common situation, especially in this kind of the world, which as policymakers need to reflect on the design of the package to make sure that even the services that are not paid for, quote unquote, are mentioned explicitly so that people are aware and they are able to demand or to access these services. We are coming close to an end, but I think I can take one more comment or reflection based on experiences in other countries. It doesn't have to be a question on the presentation, but based on your experiences, anyone who wants to reflect on the presentation or okay. Boniface, do you want to speak? I can see your name popping up.
Yes.
Budia, please go ahead.
Thank you, and thank you for great presentations. I just wanted to ask about Nigeria and the free services, and there's also a mention about the insurance packages. But is it free, or is it free and included in the insurance packages? I didn't get that. The second part is when the reference on the free services is made, do we make any allocations to ensure that the cost of providing those services is reimbursed in some form? Those are just my comments.
Okay, thanks, Boniface. Funka, do you want to take those quickly, and then we will wind up so that people have a chance to join other sessions?
Yeah, thank you, Boniface, and thank you, Jane. So the first question, so there are two major types of health insurance packages. There's the BHCPF, which was developed and is being implemented by the federal government. And then there are the state health insurance schemes, which are different. They are all ring-fenced within each state and are supposed to be contributory health insurance. Now, the reason why those two coexist is because the amount of funds available for the BHCPF is not enough to cater for all the 200 million Nigerians. So there's been some targeting done and saying that that it should only be available for Nigerians who live in rural areas. And even by the nature of the services within that package, it has already been demographically targeted. It's only women and children that are able to access those services because they are the ones that need the services within the BHCPF. So that's the free package. The state health insurance schemes are supposed to complement by providing a package of services for people who live in urban areas and have been assessed as, being able to pay for health insurance. So those two coexist, and it's not an easy coexistence. It's a turbulent coexistence. So, I mean, that's why those conversations about uniformity have been going on. The second question about allocation of the BHCPF. So the BHCPF is a statutory ring-fenced fund that is applied as 0.5% of the federal government's revenues. So whatever revenues federal government gets, it's ring-fenced and it goes into that pool. And that pool is now to get the number of people you can put on the program. You just basically find out, we have the premium for the BHCPF, and you find out how many people that pool can cover. And then you target from the bottom up, from the poorest of the poor upwards to meet the number of people that you can cover with the pool of funds. I hope that answers your questions, and thank you for the questions.
Okay, thank you very much, Funke. Let me also take this opportunity to remind the participants that we do have the presentations uploaded on the IHEA website, and some even have recordings. So please go and have a look, and you'll find perhaps some of the answers to the very specific questions. Kindly also remember that we have an opportunity to evaluate the sessions, so please go in there and see how you found this session. But most importantly, let me thank the presenters for very interesting presentations that have taken us to different parts of the world to learn about strategic purchasing. And with those few remarks, we close the session, and I wish you a good day. For those who are starting the day like us, for those who are ending the day, have a good evening. Thank you, everybody, and goodbye.